This is a special grand rounds. So let me tell you the background. We have the professor and chairman of the Department of Neurology at UW talking to us today. So the truth, the non-fictional story is that the neurosurgeons fell through for their talk this morning. So what do you do when that happens? You can only ask a friend, hey, what about giving a talk? And Bay, who has not been here, has been here less than 6 months, is a neurosurgeon at heart, even though he's a board certified neurologist and he's a neurointerventional expert. His first answer was yes. And the creative part of Bay, just to tell you a little bit about his character, is not only did he say yes, let's make it a fireside chat. I told him the story of when I invited George Lucas to the Congress of Neurological Surgeons. He showed up to give his talk without slides. So I just pulled out a couch and we sat down and we just chatted. So this is sort of in that vein. So I'm going to tell you a little bit about this gentleman who was kind enough to give us grand rounds this morning. Bay comes to us from the MGH, where he actually did his training at Mayo Clinic in neurology, but then he is fellowship trained twice, once in neurocritical care, and the second time, and he's one of those rare academicians who is also trained in neurointerventional, neurological surgeon, radiology, whatever you want to call it, but he is a neurointerventionalist. He was both in the Department of Neurology and Neurological Surgery. When we heavily recruited him to come here, I had to talk to both the chair of neurology and chair of neurosurgery, neither of which were very satisfied that we were recruiting their favorite person to Seattle. By the way, he finished, he has an active research platform. He's involved in as a PI in multiple randomized trials on stroke. He has, when you search, he has over 200 peer-reviewed papers, and he has a great sense of humor. One of the papers that I looked at was The Greening of the Neurointerventional Suite. Bay, I love that paper about how much garbage goes out of our operating rooms and interventional suites, and he was talking about how not green the stuff we do in the operating room is. So he's published over 200 peer-reviewed papers. He serves on the editorial boards of Stroke and Neurology. He's the associate editor for the Journal of Neurointerventional Surgery. He serves many societies in neurology. He's in the Academy of Neurology, American Heart Association, where he is on the American Heart Association Strategic Advisory Council, among many other roles. Probably his most important role is he's the spouse to a rehab medicine doctor who's an expert in stroke and sports medicine, and he is the father of 3 children. And Bay today is going to talk to us. He's going to talk a little bit about the Department of Neurology and his vision for the Department of Neurology. It took me 10 years to get to know the neurologists that are our partners. Bay is going to be an amazing partner. He already is an amazing partner in neurosciences, and I can talk endlessly about this gentleman who was kind enough to come and wake up early. Although he reminded me as a 2-year-old, so he probably was up for several hours. Bay, thank you for meeting the Department of Neurological Surgery and your partners in the Neurosciences Institute.
Oh, thank you, Rich. That's a very generous introduction. And I will say I'm no George Lucas. And so while George had no slides, I have a few slides that I thought I'd start with, and then maybe Rich and I can talk, and maybe everyone can participate either in the chat or via audio. So I'm going to share my screen here for a second, if that's okay.
Please.
So. Okay, so are you seeing a PowerPoint that says an introduction?
We are. We are. Thank you.
Then I'm going to switch display settings. You've seen a full screen, correct?
We do. Thank you. Yes.
So I gave a talk to the neurology department, and I thought I'd cull a few of the slides from that. And I called that talk a user's manual to the chair. So this is the abbreviated user's manual to the chair. And I wanted to follow a little bit of an agenda. And one of the things at MGH that I always looked forward to was at the end of the chief residence time, they would give an exit talk. And it was always a talk that was very focused on their families and their roots to that point. And I regretted the fact that we didn't get to know them in that sense until that last day of their residency. And so I thought I'd reverse that narrative and tell you a little bit about me, my family, my background, just so you have a sense of who I am and how that influences the way I think about the world. Tell you a little bit about neurology at UW, and then end with a slide about our priorities that Rich and I can then discuss from. So probably about 15 minutes worth of content here, but I think it'll help you understand me a little better. So I come from South Africa. It's like you dip the continent of Africa in paint, the bottom of the continent. But I actually grew up in Zimbabwe, which is this sort of teapot-shaped country here. And I grew up in Zimbabwe because we couldn't live in South Africa when I was a kid. And that's because my parents were from two different ethnic backgrounds. My father is Zulu. My mother is of Norwegian stock, but comes from Iowa.
I'm sorry?
You see that Laurel's here?
Laura's here today,
Yeah.
yes.
Can we all mute, please? Let's mute everybody. Thank you.
This is a picture of me when I was about 2 years old, before my two brothers came along. So the family unit started small, and this is what the family unit looks like now. I don't have a more recent picture than this. This is from 2018, because we were all together in London for a wedding, and I was in the wedding, which is why I'm dressed like this. But I have a brother who's a pediatric cardiologist. He is sick kids in Toronto. He worked at Boston Children's for a while, so he did his fellowship. Then I have a baby brother who is a material science engineer. And I have to confess my ignorance. I didn't know about that field until he chose to go into it. But he works in drug development for Takeda Pharmaceuticals. And there's my mother, who has aged gracefully and actually lives in Seattle. So you will maybe have a chance to meet her at some point. I went from that family unit to medical school at the University of Zimbabwe, as you heard from Rich. I then worked for the Ministry of Health. This was a pretty amazing time. This was the mid to late 90s. And Zimbabwe at that point had the highest incidence of HIV in the world and no antiretroviral therapy. So it really was a remarkable experience, a very formative experience, and underscored to me the impact of service. If you want to feel like a useful clinician, go and work in a third world environment. It's incredibly gratifying. I came to the States for residency. I interviewed at Rochester in Arizona and in Florida in December. It shouldn't surprise you that I chose to go to Florida. And I came in naive. I thought, wow, this is how American medical care is in general. I didn't appreciate this first year or two how special Mayo Clinic was. Mayo Clinic was amazing. Those of you that have been there can attest to that. And what really struck me was how well they implemented and used systems. They were very, very efficient in the way that they went about the business of healthcare. And then I went from Mayo to Boston, and I did a neurocritical care fellowship at MGH at Brigham, and then stayed on and did an endovascular fellowship. It has a long name, as you see on the slide, but been tightened down to just neuroendovascular at MGH alone. And I have to tell you, when I first made that move, it was a little bit of a surprise because as vaulted as the Harvard system is, it didn't have the bells and whistles that Mayo had. But one thing that the Harvard system does have, and is not to be underestimated, is people, incredible people. And I felt very privileged to both train there and then subsequently work there. Rich mentioned my better half. My wife is a rehab physician. I met her in my first year of residency, and we got married a few years later. We've been married for about 15 years now, which is hard to imagine. She is here. She's going to be part of our efforts at the University of Washington. She is a fellowship-trained TBI and stroke specialist, and so she's going to be the director of stroke rehab. And you'll see her both at Harborview and here at Montlake. She actually started work on the 1st, which was Friday. I chose this picture of her not just because I'm proud that she was the cover of the Top Doctors edition this year, but because she stands like this at home as well. She's a very, very strong lady, and I think you'll have a really good time meeting her and working with her. And so while I was at MGH, I had this career duality. I was in neuroendovascular and neurocritical care, and I bridged the two departments. I spent about 75% of my time in neurosurgery and 25% in neurology. And I have to say, it was a very interesting perspective to see those two sides. And there's a member of the neurology faculty called Stephen Tapscott, who was telling me a few months ago about how when he's talking to his mentees and they have interests that are disparate, and they ask him, what should I do? How should I pursue this? He tells them, do them both. And you're passionate about both, do them both. And what you'll do is you'll make a connection. And because there wasn't one before, that connection will be novel. And that really was my experience with this. There are many neurologists that do stroke and endovascular. There are not that many that do critical care and endovascular. And I found that it was a very invigorating combination. Now, in 2015, I'm sure you're aware, there were some landmark papers that were published about large vessel occlusion stroke. And large vessel occlusion stroke was not a tremendously big part of our practice. We have about 1,400 procedures in the endovascular side at MGH, and about 140 was stroke when I left. Back in 2015, there was only 55 or so. So it wasn't a big part of our practice. But I have to tell you, it's an incredibly gratifying part of endovascular practice. If you coil an aneurysm or treat an AVM, the patient looks the same before and after. But you pull a clot out of an M1, the patient can be resurrected. And there's nothing that has that kind of immediate return in the endovascular space. And I really enjoyed it. And these papers came out and they showed how powerful this treatment was. And this was the thing that really, for me, triggered my move beyond just clinical care. And the trigger was that I'd be in the endovascular suite waiting for a transfer to come in. And long before the patient's head got to the donut, I felt like the patient's fate had been determined by the way that they were processed and transferred in. Every minute counts with stroke, and the processes were just so inefficient. And so I started to work with our EMS, and then with our Department of Health, and then at a state level and regional level, then at a national level on systems of care pieces and how we can optimize the way that we handle patients. And that proved incredibly gratifying to me in a way that I had not expected. I thought that it was important for our clinical care, but there was something about having an impact that was at that scale, and for people that you would never meet individually, that somehow very satisfying. Then the pandemic came along, and I think, like all of you, it made me pause and think, what do I want the next 20 years of my career to look like? And it was in that context and at that time that this opportunity at the University of Washington presented itself. And when I looked at the Department of Neurology, I saw those three things that I mentioned to you earlier: the service, this local area plus whammy. That's a really unusual and unique combination. The systems with the multiple hospitals, the complexity of it, and then most of all, just incredible people that work here. And so it was a very appealing opportunity, but it came with a price that was a very heavy price. And that was the question of what would happen to my endovascular life. The expectation was that I would be 80% administrative and 20% clinical. And so if I'm going to do that, what does that mean for maintaining a practice, maintaining a skill set? And it became increasingly clear as I went along that I would probably have to give up endovascular work. And I have to tell you, that was almost a reason why I didn't come. It was such a big decision. I spent many nights lying in bed looking at the ceiling and thinking about this. But I don't think you ever get something in life for nothing. And so I view this as the price that I have to pay for this chance. And as I said to our neurology faculty, in some ways, it is an opportunity for me to go back to my first love, which is neurocritical care, and to refocus on that alone. So Rich mentioned I have 3 kids. This is what they look like. This was a picture that I texted to Jana and to Nick Poulos when I arrived. It is our rental in Eastlake. But I have a 10-year-old, an 8-year-old, and the notorious 2-year-old. And here's my wife. They're a lot of fun, and they've really enjoyed making the move over here. And it's been a big transition for us, going from Boston to Seattle, going from Harvard to the University of Washington, making a move from being a clinical workhorse to being an administrative one, which is maybe the biggest of the transitions. And I commented to our neurology folks that the allegiances that have been tested across the board, I was surprised at the level of anti-patriot sentiment, I must say, but I remain a steadfast fan. And I've asked myself a lot this question: what is it that a department does? A department nourishes and supports patients, providers, and the specialty within the larger context of care. And so let me tell you just a little bit about the neurology department here at the UW. This is a picture from 1970 on the left. In 1970, the discussions about the division of neurology in medicine breaking off and becoming a separate department really began. And there was an interesting quote from the chairman of medicine at that time. His quote was that he refused to balkanize medicine. That is neurology today, but it'll be cardiology tomorrow, and then nephrology the day after, and we're just not doing that. And so it was only 25 years later, if you can believe it, that neurology actually separated from medicine as a separate department. We were the 5th or 6th last department in the country to form, so it was a late change. But the founding chair here, Bruce Ransom in the black jacket, was recruited as the first chair of the department. And he was actually about my age when he took over and started the Department of Neurology. I had a chance to meet him several times on Zoom and then in person. Here he is, he's in Hong Kong, and it was 9 a.m. in the morning, and I was in Boston. This was our kitchen, and it was 9 p.m. at night. And I always think about Bruce as the most interesting man in neurology. He's a real character, incredibly brilliant man, and he has been so welcoming and helpful. But the department that he created and the department we have now are very, very different departments. And so here's a picture of some of our department, and I'm sure that when you look at this, you'll recognize some faces, but I'll bet you there are many people that you've never seen before here too. We have a large group, about 150 people that fall under the umbrella of neurology. And like you in neurosurgery, we're spread out. We are in these 5 different clinical sites and then various research sites as well. But like you, we have a single mission, which is to improve the health of the public. And you could argue that it's to improve the neurological health of the public, and I wouldn't dispute that. Now, the challenges that we face in neurology and in neurosurgery are similar and different. And I wanted to highlight a couple of the things that we're really challenged by in neurology. So there's this issue of mismatch. It's a term that you may have heard. If you haven't, you'll hear more about it to come. But mismatch is the idea that the provision of services, represented here by the purple stone, is far outweighed by the demand for those services. And it's an adaptive problem, meaning that it's a problem with multiple facets that changes rapidly. Just think about how much change we've had in the last 2 years, for example. It's a problem where historical solutions are insufficient. That's why there's a mismatch. That's why there's a problem. It involves multiple stakeholders. You have the patients, the providers, the hospital systems, various organizations like insurance companies. And it requires a little bit of thinking outside the box for us to solve. There's not a single solution to it. But this is a major challenge for neurology as a field. And it's a challenge because there've never really been enough neurologists anyway. And we have this aging population. And neurology is a geriatric specialty. And so the number of patients on the horizon is substantially larger than it is now. And the estimates are that in 2025, there'll be more than a 20% mismatch across most of the country. And our region is no exception to that. So this is a major challenge. And the other major challenge is that we have some reimagining that we're going to have to do because therapeutics are coming. This is a picture of a man called C. Miller Fisher that some of you may know. He was the father of stroke in my mind. He's the person who described AFib stroke. He described carotid disease and stroke, lacuna syndromes. He described vasospasm and subarachnoid hemorrhage, actually an incredibly broad-ranging mind. He was one of the stalwarts from MGH. And so when I used to walk down to my office every morning, his picture was at the end of the corridor. And I would think about him and I'm not embarrassed to admit, talk to him in my mind, walking down that corridor. And I would think about how different the world of stroke was for him than it is for us today. You know, the idea of thrombolytics and rushing people to the scanner and rushing them up to the angio suite. And the reason it's that different is that we have a powerful therapeutic option. Now, in neurology, this range of therapeutics that are coming are going to mean that we reimagine various areas of our specialty. It's going to be a very different specialty in 15 years than what it is now. And so we have to prepare for that as well. And I'll say that there is no path alone. I was very excited to hear about the Neuroscience Institute as an initiative. It's an initiative that is growing and forming, but the idea is that we have to think in disease-based terms. We have to work together. And we have to think outside of our own specialties. And it's not just medical specialties here. I've listed psychiatry and rehab and internal medicine. Think about computer science, bioengineering, all these other various areas that will impact the work that we do in the future. And so my last two slides are these. I mentioned that we've been thinking in priority terms. You know, I'm in the listening and learning phase of joining you here at UW. And what I've been thinking about mostly is what are our priorities as a department? Because priorities are what you build strategy on. Strategy is what informs the tactics you apply. I think often we jump into tactics, but we need to have those earlier blocks. And I think for us to improve the health of the public, these are the 4 priority areas: building, expanding, innovating, and including everyone. And so I'm actually going to stop here. Rich had promised a fireside chat, but there are no cigars or brandy. And I think we will open the floor.
Yes. So what, Bay, that was fabulous. And, you know, needless to say, the fact that you showed up at the last minute and gave this just beautiful talk, it really says a lot about who you are and the character of the man. So I'll start off with the first question. The mismatch. What are the creative tools that you think you can use to train maybe perhaps other people to do some of the things? Like, there are over 1 billion people in the world right now that have chronic headaches. How do we manage these unmanageable conditions?
So you know, I think when you think about mismatch, I like to think about it in demand and supply terms. And you know, you're talking, Rich, about the demand side of that equation. How do you modulate demand? And so you can trim demand that's inappropriate. So think about, for example, the number of referrals that neurology gets for diseases that are somatic in nature. If our medicine colleagues, family practice colleagues had a little bit more knowledge about certain areas, that referral burden will decrease. You can modulate demand by coping with what you have better. And so you think about improving our access processes. We know there's demand out there. How do we cope with it better? And then you can modulate demand by creating a new paradigm. And I think a good example of that is procedural work. So you think about, there's Michael. Think about Michael doing a thrombectomy and what that means for the burden of that patient's disease downstream, and therefore the burden on the system. You think about epilepsy surgery or DBS implantation. You really modulated demand by making the disease better for the patient. And so it's a multifaceted entity, but the example you give about headache is a really good one. If we can train people at the non-neurological level, internal medicine, family practice, etc., to manage headache better, or change the triage process up to neurology, that'll have a big impact. And headache is it's the commonest neurological problem in the world. It's a major source of demand.
Thank you. Mike Levitt, you just went live. I know you've been here the whole time. Mike is one of our neuroendovascular and open vascular faculty and who has a lab. Mike, do you have any questions for Bay?
Sure. So first of all, I just didn't think anybody wanted to watch me eat my breakfast. So Bay, I know we had actually had a chance briefly to talk and meet, and I think to me the interesting part of your journey is essentially the feeling that you basically had to cut off one of your hands in order to come here. So I know you touched on this in your talk, but for people who are going through a major transition or who are
We're losing you, Mike.
Breaking up a little bit, Michael.
How do you weigh the I mean, hard to do you think you would ever go back? No, I'm just kidding. But do you think you'd ever go back? Did I lose you?
I think we got some of the question. Did you get some of the question, Bay?
I think so.
Here, let me. I had a bad connection. Can you hear me?
Yeah,
I hear you now. Yeah.
Yeah. Okay. Oh, yeah. So the question was, do you think you would ever go back to interventional? Do you think that that's in your past now? How do you weigh a decision like that, where you spent a long time and a lot of hours and a lot of late nights doing something that you at this point are not doing, and how do you go about making a decision like that, where you're really shifting your entire professional persona into something that you probably haven't had a lot of experience with? You weren't a chair at MGH. How do you make that calculus, and how do you prioritize your own practice versus a system in the way that you've had to do? And then would you ever go back to taking to doing that kind of work? And then the last question is, will you cover my stroke call next weekend?
I knew that question was coming, Michael. So I would say that I think those decisions are never easy, and when you are weighing opportunities, the question is, what do you gain, and what is the trajectory of what you gain versus what you lose? For me, I had that slide with various transitions. One thing that I think many of you can appreciate is that there's almost an identity transition involved in leaving your endovascular work. Not just your national identity, but your personal identity. That's how I view myself. Now I'm not doing it. What does that mean? And I'm sure that you've had experiences like that in your careers. However, this is also a unique time in our country. I think that institutions are willing to do things they haven't been willing to do in the past. They're willing to take risks potentially they haven't been willing to take in the past. And an opportunity like this is a rare opportunity. And so if it had been a different university, in a different environment, would it have been the same pool? Probably not. But for this university, in this place, at this time, it was something that I felt I couldn't say no to and then look back without major regrets. Now, as to whether I'll have a chance to go back to it, I think we'll see how things look after this year. I'm going to do some ICU time. I have about 8 weeks on service this year, and I'll see how that feels and how that balances. But I don't miss stroke. And I will say that the implications for my family have been very profound, much more so than I expected. You know, I was on service for 2 or 3 weekends a month when you added my endo call and my ICU time. And so just that alone, in terms of what it means for me and being able to be with my children, has been dramatic. And I think you can appreciate that from what happened during the pandemic and things slowing down.
That's a great answer. Chris Young, you just went live. This is our chief resident from, originates from South Africa, was a Rhodes Scholar from South Africa. I saw you light it up when he talked about his origins from South Africa. Do you have a question, Dr. Young?
Yes, thanks, Dr. Leslie-Mazwi. Thanks, Dr. Ellenbogen. Dr. Leslie-Mazwi, with your background in Southern Africa, something that has frustrated me somewhat in neurosurgery is that a lot of the treatment that we have is 4 to 5% of the world. Thrombolysis, with this time frame, really struggle to really take off in large tracts of the developing world. And endovascular service, obviously, it's also very costly. What is your thoughts on how we take this to, at an international level to where there's really very high disease burden of disease?
That's a very interesting question. So first of all, please everyone call me Bay. My name is a mouthful. Bay is really easy. I prefer that. So I think when we think about the environment that we practice in here, the model that we have is actually a model that's true for most of the planet, right? We have a very centralized, highly specialized center that serves a very large geography. And so the solutions that we arrive at here are going to be solutions that can generalize in a different way to the planet. And so I think that in our system thinking, that's something that we should remember. Secondly, I would say that we're very fortunate. I mean, one of the things about those trials in 2015 was that it made me think, how lucky are we that we get to offer these services, and that as a population we get to partake of these services. Most of the world doesn't have that opportunity. And so we have this tremendous responsibility to use them effectively and efficiently, push the species forward, even if we can't address the problems in every level of the world. And then the final thing I'd say about that is that the developing world has a different range of challenges. And it just doesn't make sense in my mind for these very high-end, very expensive services to be priorities in the developing world yet. I mean, the infectious diseases, just basic vaccination rates, those are the kind of things that will have a much bigger impact. All the aspects of nutritional problems, there are a range of vascular risk factors that aren't managed. That's a much cheaper intervention than developing an endovascular practice. So we have to think of ourselves as the tip of a spear here. But the solutions that we have will not necessarily be solutions that generalize.
That's a great answer. And the person whose hand is raised next is most like you in clinical practice, Melanie Walker, who, as you know, is in the Department of Neurological Surgery and Neurology, really a great collaborative recruit that we have, who's a stroke neurologist and ICU trained, who does neurointerventional. Melanie, sorry I gave an introduction. I know, Bay, you know her. Melanie, question?
Just one question. Sorry, I'm not going to kill my bandwidth by putting video on, or also like Mike, I don't want to see me eating my breakfast. I just have one question, and that is the role of industry in your vision. I've struggled at the University of Washington, to be honest, to bring an industry perspective. Even just, Rich and Mike and Lewis know just really hard to find a way to partner with industry in an equitable way. And, as you say, there's a lot of stuff on the horizon that isn't just, pie in the sky stuff. It's medications and devices and things you can do in home. And really, like you say, you want to change the paradigm about headache. A lot of it is going to change the way that you behave, and it's hard to do. And I don't think we can do it without a market and industry support. And I wonder what your vision is as chair and as our co-faculty and our friend and our partner, how you think about it.
Yeah, excellent. So I think there's several layers there, but I'll focus on the clinical practice, the clinical volume and clinical service. What we need from industry is to be a partner to them in implementing the things that they have developed, right? And one very low-hanging fruit is with clinical trials. So if you think about trial hierarchy in many academic institutions, you have NIH-funded trials as sort of the top of the pile. And industry-funded trials tend to be a little bit less glossy seeming in the eyes of the institution and the eyes of the department. But I don't personally subscribe to that. Industry-funded trials are pragmatic trials usually. They often pay well in terms of enrollment and support for the trial. And as you say, Melanie, they're typically testing a therapeutic. And so it's a shorter bridge from the trial to a clinical impact than some of the other things that you might be investigating. And so if we can provide a robust clinical practice that can feed patients into clinical trials, we make ourselves very attractive to industry. What that means at the departmental or the neuroscience level is that we need to have the infrastructure to provide that support. So we have the clinical volume in clinics or in the inpatient services. We have the infrastructure to support studying that clinical volume. And then we make ourselves very attractive to industry partners. So I'd say that's one really big piece. And that's a partnership that can extend over a long period of time. We have Marie Davis in our department who's looking at a phase 1 trial with Biogen for an intrathecal therapeutic, right? If that phase 1 trial is successful, there'll be phase 2 work that will be part of it. If that's successful, there'll be phase 3 work that will be part of it. Maybe even be able to direct at some level because we were there at the beginning. And so I think that sort of collaboration is going to be critical. The other piece with industry is the philanthropic side. And I think we have some opportunities we have to explore more when it comes to philanthropy. Most of the neurology department's revenue is clinical. The same is true for neurosurgery. Our philanthropic components, the gifts and endowments and so forth, I think that's the piece that we can grow most effectively. And so you think about Lewis Kim's aneurysm center, for example. There's some opportunities there because we have a target. You think about stroke, there's some opportunities there because we have a target. You think about all the various areas of development in neurology, there's some opportunities there, we have targets. And so I see the industry interaction in those two ways. But I don't see it as a dirty word, and I don't see it as something that we want to avoid. I think that partnership is good for industry and it's good for us, and therefore it's great for patients.
Thanks, Bay. Lewis, thoughts? A question?
Thanks, Bay, for being on like this and being on the spot, so to speak. It feels like an interview more than a fireside chat, so I apologize for that. But and also you're showing your real anti-American, extra American roots by not realizing how much the world hates the Patriots outside of Boston. So just update. It's not a Seattle specific problem here. But all kidding aside, I think I really like the part where you talked about disease specific care that Rich is really a proponent of, and I think that's a real, a gem, if you will, of how we're going to collaborate better with neurology and neurosurgery and in a way that we're all incentivized together in the same direction. And I wonder what your thoughts are about trying to implement that kind of a pathway in other areas of neurology, neurosurgery interface, and where you think that might work best, what sort of big topical areas of the Neurosciences Institute. So kind of leave it open-ended.
Yeah, no, I couldn't agree with you more, Lewis. I think we already have a model with the ABTC, right? Think about Manny and Lynn and Leah working in a disease-focused way in our neuro-oncology space. And that's an area of growth. It's the best the ABTC has been, actually, in the last decade. And so I think we have some areas where we're doing this well already. When you think about our department, distinct from neurosurgery, just neurology alone, we're really challenged by the geography that we lie over. So we have faculty in these various hospitals, and unlike your neurosurgery department, where you as faculty move between various places more, most of our neurology faculty tend to be fairly hospital specific. And as a result, the departmental identity is not as strong as I'd like. And so we need to work on that horizontal bridging. When you think about the disease-specific nature of something, you think about epilepsy, for example. We need epilepsy to be a band across the multiple sites. I think having that sort of divisional identity makes multifaceted collaboration easier. Because then we have different kinds of capacity, we have different kinds of economies of scale, we have different kinds of flexibility. And so that's going to be one of the big things we work on in these next few years, is trying to build out our department into clear divisions that cross Harborview, Montlake, Northwest, Children's, and the VA, and allow us to provide services across all five in a different way. So, vascular is clearly a focus. Onc is clearly a focus, epilepsy is clearly a focus, movement disorders is clearly a focus. I think those four immediately jump to my mind, but there are multiple areas where I think we will have touch points. I saw Mike Williams pop up for a second. Think about hydrocephalus and neurology and neurosurgery, for instance. In fact, I see Mike Williams has his hand up. Hi, Mike.
Hey, good morning. So actually, I have a question for both you and Rich. And Bay, I know that my career is similar to yours. I came out of neurocritical care, and I'm seated in the Department of Neurosurgery. And one of the observations that I've made, not just here at UW, but at my previous institutions, is that I think we are not training our residents to understand what actually can happen between departments. Neurology residents really don't have any idea what neurosurgeons do, how they think, what they know, their mastery of neuroanatomy, and how they size up risks. And I think many neurosurgeons, but not all neurosurgeons, don't completely understand what neurologists do, particularly from a diagnostic end of things. So my question is whether you and Rich have some thoughts on how we might better integrate the training of our residents to appreciate our areas of overlap, because that plants the seed for future specialists to move forward with this type of vision.
Rich, you're on mute.
Mike, this is our first step. I mean, Bay took the first step here. Bay, why don't you answer that? But I think this is a really great start.
I was actually going to punt that to you, Rich, but I would say working in both departments at MGH for me was very eye-opening for exactly that reason, Mike. I saw our MGH neurosurgery department evolve over the time that I was there. So, for example, the department that Manny left is different from the department that Anoop left, and it's different from the department that Ben left. And in my mind, it got progressively more empathetic and progressively more collaborative. It was always an excellent department, but it just evolved in that way. And the old saying, the opposite of competition is collaboration, right? So the neurosurgeon mentality and the neurology mentality are very different mentalities, but there's so much more common ground than I think people appreciate. And when I say that the department became more empathetic, what I mean is that there was less of a tendency, in my opinion, to be critical of other services and other efforts. You know, the funny thing is that everyone is working hard. Everyone is trying their best to get the best outcome for patients. And it's easy to say, you know, these anesthesia guys, the cardiologist or the infectious disease doc doesn't get here on time. But everyone's trying to pull their weight. And the more that we understand the roles we play and the challenges we face in those roles, the better we'll be able to do things together. The more we look outside our specialty, the more collaborative things become. So I agree with Rich. I think that this is going to be a really exciting time. I think there are a host of different points of connection, training, research, clinical care. And we already share an administrative structure, which for me was one really positive departmental element, that we're already joined at the administrative hip and with such excellent administrators. We just need to make the other points of connection as strong.
I'll second that. I think the solution to, I always say the solution to pollution is dilution. My first grant had Joe Zunt as the neurologist running it. Okay. And and I didn't know what Joe Zunt did, and Joe Zunt's a professor now, but I mean, it was wonderful. And so I think that more collaboration is about to happen. It's been great in that way. I want to pick on Manny a little, because Manny is an MGH Boston guy that I want to just say is probably my best bellwether fan for the Seahawks. I mean, he is the best Seahawk fan I've ever seen in my life. And he is a Boston guy. So it can happen to you, Bay. It can. Manny, questions for him, for this Patriot fan?
So I'll say one thing for Bay, and some people may not know this, but the reason why Lewis and I feel so passionate is that we were on the 20-yard line at the 2014 Super Bowl when that was robbed from Seattle. So me, him, and Fungi Zhang, Raj Godke were all there together. So it'll never be the same. I think, Bay, thank you very much again for, getting up this early. We're all very, very excited to have you here. And the future is brighter than ever. Certainly, I can already feel it within your department and the Department of Neurosurgery. Both you and Lewis touched upon this, and that is, for me, training at the MGH, and this is no news to you, but you're under one roof, physically, literally, and figuratively, and that is the leadership all seem quite aligned, right? And here we are stretched across different campuses. I think within departments, we know which direction we're going, certainly in neurosurgery, and I would extend that to neurology now. You alluded to the program in the Albert Brain Tumor Center being in a position it's never been before. Certainly in my 12 years, we have not had the team in place that we have now. I feel like we're the 2011 Seahawks, right? Coming up to that 2013 Super Bowl run. What are the first moves to essentially align the leadership across these different campuses under one vision? I can already see yourself and Rich are aligning across these different programs, but how do we get the different cultures in the hospital, the different cost centers or financial priorities aligned for the Albert Brain Tumor Center? Because not only are we poised to serve Seattle and the WAMI region better, I think nationally and internationally, from a clinical perspective, education certainly, and then this research piece that you mentioned earlier. We're sort of on the brink of launching. What are the first moves in your mind?
Yeah, so I think that we begin by articulating a very clear vision for what we want and a unified vision for what we want. And that's one of the things that the Neuroscience Institute is going to be important for. It's an institutional priority. And part of that is financial. You think about Harborview, a large portion of Harborview's revenue comes from the neurosciences, right? Neurosciences, ortho, spine, that floats a host of other services at Harborview. So it's a priority for our hospitals, it's a priority for the institution strategically. But we need to have a very articulated and cohesive vision for what we think is necessary. And I agree with you, Manny, the complexity of the structure here is that each hospital is its own entity, departments cross multiple hospitals, staff are affiliated at multiple places. But one thing I can say as someone coming from outside and being struck by it, and honestly how inefficient it is and how much it hampers our progress, is that I think there's an increasing realization of that at the highest levels of leadership. And so there's an appetite and an enthusiasm to change that we haven't had before. I'll give you a couple of examples. I mean, you think about telehealth, right? We don't have a UW articulated telehealth approach. We have an effective telehealth service, but it's so fragmented compared to what it could be, and it offers so many disparate things compared to what it could offer. But that's something that we're seeing actively evolving. It's actively being prioritized. And so I think that the combination of our enthusiasm for it and the institutional enthusiasm for it brings us to a point of convergence. You have all these vectors going in different directions. If we can bring them into a point of convergence. And then at some level, it always comes down to the money, right? How do you afford it? Who's paying for it? How does the funds flow? And so being articulate in our vision will help with that. Rich, I wonder if you have anything you want to add to that.
Yeah, I have only one question. Will you ever go to a Seahawk game? Because because you between Manny and me, you're going to get invited. So and
I'd love to come, but I can't promise I'll cheer for the team that you.
So no, I agree. I mean, you pointed to the money issue is an enormous issue, but I look at Manny's skull base program, pituitary program. The way that we launched that is we shared revenue initially, and all of a sudden there were a lot of endocrinologists that wanted to be part of that, and we went from 40 operations a year to 240 operations a year. So I think what you say is very honest and very truthful. We just got to find more areas of intersection, and boy, you and I, or our departments, have a lot of areas: epilepsy, stroke, brain tumors. You listed them all. But even motor neuron disease, you know, there are areas that we haven't even thought about that we just need to think differently about. So I love your answer to that. I think it's endless. Before I see Jeff Ogeman popped on, and he's wearing scrubs, which is, oh my God. Are we letting you in the operating room now, Jeff?
Well, you'll notice I'm not in the operating room.
Okay,
So
all right. So I'm sure you.
It's similar to Dr. Kim and others. It's
oh wow.
But I would Bay, good morning, and maybe you and I have had some great initial conversations about the resident research training, and I think that's something that you brought a ton of energy into, and maybe a couple comments about where you see that going for both your own team and residents, but also the neuroscience community generally. And you've touched on some of these themes already, but I think it's a vision that I've heard, and I think everybody should hear some of.
Well, I can tell you that my personal experience was coming to Mayo and then MGH without a big research background, right? I came from Southern Africa. But being involved in clinical trials as a trainee is really what made me interested in it as an attending. And so I think if we are able to provide a clinical trial landscape that our trainees can participate in, they're going down to the ED to consent patients, or they're doing follow-up visits in the unit or something similar. That kind of engagement is the kind of thing that lights a bit of a fire in some. Then we offer a structured research curricula. Jeff has the R25. I'd like us to participate more on the neurology side than we have. I think we have the potential to be better partners there than we are now. And I'm really looking forward to nurturing that aspect of our department. And then, there's the idea of the entire pipeline. Rich has an R25 that he uses for scholars that come from outside the institution, undergraduates. And I'd love for us to participate in that too, and show these undergraduates an experience in a neurology lab environment or a neurosurgical lab environment that gets them excited about the sciences and about participating with us in the future. So I think there'll be many levels at which we can reinforce and enhance the resident experience, and at the end of it, produce more sort of clinician scientists, clinician researchers, because that's what's going to help push our field as we go forward.
Hey, thank you. And you're already on the R25 for underrepresented minorities. Nina participates a lot. Nina, questions for Bay?
I'm very excited, Bay, that you have this ICU background, and I look forward to work together. And I'm thinking that a great opportunity is to use big data, to integrate, like heart rate and autonomic features in the OR, measure it for neurosurgeon, but also for neurologists to get a better understanding of the mechanisms of the disease and what happens really during a crisis. So I think combining neurology and neurosurgery will be very, very important, and combining it with Seattle Children's will be also great. Mark Wainwright is working very closely on that. So
that's a good example of the comment I'd made earlier about this divisional identity and the benefits of that. As Nina pointed out, Mark Wainwright's doing a lot of big data work at Seattle Children's. On the adult side of the neurocritical care unit, we don't have much of a footprint there. But there's a lot that we could learn from our children's colleagues about how they're approaching that, what data they use, how they mine it, how they refine it. So I think you're absolutely right.
Yeah, Dr. Shaker is very interested in that, and I think it's just a waste of information that we're losing all the time without having good integrated, software.
Well, one degree of separation is Rob Bono, who's a neurosurgeon who does neurointensive care, trained by your colleague, person you trained, Bay, Sarah Wassler. And so one of the great areas, I think, I'd love to see the neurology, neurocritical care, neurosurgery go forth and multiply at other hospitals other than at Harborview. I'd love to see it at the University Hospital. Manny knows my feelings on that. And so, Rob, why don't you ask Bay a question?
Yeah, thanks, Dr. Ellenbogen, and thank you, Bay, for this talk. It's been really insightful and great to meet you by the fireside. I think neurocritical care at Harborview, or at least at UW, since Harborview is where in the UW system neurocritical care lives, has always seemed sort of like it's between departments, never really had a real home. And I was just kind of wondering, aside from the academic research potential that Nino just touched on, what you thought about the kind of the future of that practice at Harborview and at UW, and what advantages and challenges you see our system offering going forward for it.
So I think this will end up being our last question, and it's nice that it ends in neurocritical care. So thanks, Rob. This has been a topic of much discussion. As I said, I'm in the listening and learning phase, but it does strike me we have a multidisciplinary group, which is a pretty uniquely multidisciplinary group in the neurocritical care environment, and we don't want to lose that. But I think we need a little bit more neuro representation. And so I'd like to see more neurology trained neurointensivists. I'll be one, Sarah is two, Pratik is a ±3, right? But I think we need a few more. And we've been talking about the identity of the neurocritical care unit as a distinct entity with a limited number of providers. And those discussions are happening in a larger umbrella. So you may or may not be aware that medicine is discussing a critical care center where all our critical care falls under a separate umbrella. And so I would say that those are discussions that are in process, but I think there is an acceptance of the fact that subspecialization in that domain leads to better patient outcomes. We would rather a unit where we had a core group of faculty than a unit where many people rotated through amongst various other unit experiences. And so we're working towards that.
May I speak for everybody and all of neurosciences? I'm going to be bold enough to say we are so excited to have you here. It's been pretty amazing. It's been a fun ride, and just your actions have been your autobiography. The fact that you showed up this morning and your answer was just simply yes, and so thank you, Bay. You really wonderful.
I appreciate it. Yeah, no, thank you, Rich. And I hope that you folks see me as an approachable and accessible individual. Please feel free to reach out to me directly with anything that comes up. And I've met some of you, Manny and Lewis and Andrew. And I appreciate that, and I look forward to seeing you in person soon.